So thank you everyone so much for joining. I'm taking a look at the attendee list and the participants on right now, and I'm seeing a lot of names from across the state. So that's really exciting. I'm seeing a bunch of different folks from a bunch of different counties. So we are going to get started. So welcome to the third webinar here with Vital Strategies in PERU, which is promoting community mobilization for harm reduction. And so this is the Racial Equity and Overdose Prevention Part 2, Strategies and Practices. So we'll go ahead and get things started. We are going to go over just some housekeeping items. I see some more folks joined here. So really quickly, this webinar is being recorded. So we're just asking that all stay muted other than the panelists. There are two options. You have the chat and the Q&A function that should be located at the bottom of your screen. So if you could just put all of your chat and Q&A boxes there, or questions, we will filter those out. And then there's also an evaluation at the end. And so if you could just please fill that out. So hi everyone, my name is Marco Puglisi. I'm the lead technical consultant with the University of Pittsburgh Program Evaluation and Research Unit, specifically the Community Health Initiatives, or CHI. So again, a lot of you may know me on the call. I see a lot of familiar names. So I'm currently with CHI, and I will turn this over to Tracy over at Vital Strategies.
Hi, welcome everybody. My name is Tracy Pugh. I am a senior manager at Vital Strategies for the Overdose Prevention Program. And welcome to, I think this is our third webinar in our harm reduction series that we have been co-hosting with PERU. And so we are really excited to follow up from our last webinar on racial equity and overdose prevention, looking at data. And so today we have some great guests for you, David Saunders and Dr. Kima Taylor, to talk about how to now go to work and put strategies and practice into action to advance racial equity in overdose prevention work. And so with that, I'm going to turn it over to David Saunders to introduce himself and provide a little background, and then Dr. Kima Taylor.
Yes, my name is David Saunders. I'm the director of the Office of Health Equity. I've been in that position now since May of 2016. And this has been an interesting time period, both with the pandemic and the racial unrest. So I think the topic at hand is one that should be interesting for us to all kind of look at as we address this topic. So thank you.
Dr. Kima Taylor.
Yeah, thank you. As Tracy said, my name is Kima Taylor. I'm a pediatrician by training, and since medical school, I've really focused on how to decrease racial and ethnic disparities and inequities in all areas of the healthcare system. So not only in terms of patients and patient outcomes, but how to change the system itself in order to achieve equity. I have worked in myriad spaces in terms of providing care for predominantly uninsured patients, worked in the Hill for a bit, worked as Deputy Commissioner of Baltimore City, and then at foundation level. And now I'm an independent consultant, and really excited about this conversation. As David said, it's an interesting current time. And since so many of these inequities are embedded from the history of our country, it's about time that we actually take the opportunity to change this.
Absolutely. So with that, this is the list of our webinar objectives. And this webinar is going to be a little different from the prior ones in that we're going to take a more conversational tone. I know folks have been, in our previous webinars, we went through slideshow presentations and a very traditional didactic approach, but we're going to be a little bit more interactive in having the speakers kind of talk to each other and with the audience, kind of going through these objectives one by one or bouncing around. And so with that, I think we are going to get started with our first topic to start on. And maybe David Saunders can lead us off to discuss utilizing a racial equity lens when developing health-based interventions. What do we mean by this?
Interesting. Well, I think what we mean by this is, first recognizing the impact of systemic racism. And also, I think in this space, as it relates to substance abuse, harm reduction, I think it's also important for us to kind of look at the social determinants of health. I'm sure many of you are aware of where we live, work, and play, and how that impacts health. I think specifically some areas that connect with substance abuse, some of the social determinants of health that connect with substance abuse would include housing. This is clearly not an exhaustive list, but would include housing as well as education, access to health. And we're seeing some of that play out as it relates to the disparities of that are being highlighted from COVID-19, just some of the ways that certain folks are positioned in an adverse way as opposed to others. So just a few points on that.
Mm-hmm. Yeah. And what are some of the pitfalls or challenges do you think should be expected when doing this work or advancing a racial equity lens in a health-based with health-based interventions?
I think there's so many competing priorities. So now here we are in the state of Pennsylvania, still largely white, very much rural, but in many of the areas of the state, some of these rural pockets of folks, on the line representing various counties, those counties are changing in that there are growing racial and ethnic minority populations within these rural pockets. It may still be small, the percentage may still be low, but these racial and ethnic minorities that exist, that reside in some of our rural counties, it poses a challenge when you're accustomed to going about things in a certain way, and you have to look at growing racial and ethnic minority communities. And what I tell folks all the time is, that immigrants and refugees that have come to our state, come to our communities, they come here for a reason, and they're not going back in many cases. So that population will only grow. So I think it's incumbent upon us to a certain extent, as much as possible, kind of get out in front and making sure that the staff that we have on board understand the cultural nuances, have materials in various languages and not just Spanish and Mandarin and Cantonese, but various other languages. So that's just a kind of a starting point. Again, those cultural differences and what certain groups believe and the myths and stigma involved with or connected to substance abuse, need to be addressed. And we need to tease that out as we go forward.
Mm-hmm. Great. And Dr. Taylor, you've been doing this work for some time on different sides as a practitioner, as being in different organizations and boards and consulting, and from a health lens and from a drug policy lens. What do you find is the best way to go about utilizing a racial equity lens in this work?
Yeah, I think for myself, there's kind of two big pockets. And the first one touches on something David said. It is that systemic racism, but it's really looking at the history, right? And I think we have to be really honest that the history of drug policy is racist. History of many of our institutions are racist, but it wasn't just accidental. Like, there are policies and practices that are baked in that says people are other and not deserving and not worthy. And so we really have to, honestly, using racial equity lens, we have to go and study our history and dismantle those systems. It can't be tinkering at the edges. We really have to rethink how we treat people using I believe, a human rights lens. And so I think a lot of times people want to put programs in place and pretend nothing happened before. But if you do that, you don't understand how these policies are so baked in. You're just going to perpetuate the same inequities. And that kind of gets me to the second point. Because so much of these policies, practices, and beliefs were baked in, not just through the war on drugs, but health systems and social systems and other systems. Societies, Black societies, Indigenous societies, other people of color had to save themselves, más o menos, right? And so a great example of this is in HIV, when the government really was structured to not help people. And that's how a lot of the harm reduction and syringe exchange and other pieces came out, because people were like, we're saving ourselves. And so that gets us to the second point. You have to, if nothing else resonates in this talk to the people you're serving. And, you have to go out and talk to Black communities. You have to go out and talk to the Indigenous communities, every immigrant community, whoever is in your community that you are serving, but also that you wish to serve, that you want to come in and they're not coming to your doors for some reason that you don't quite understand. It's going out and talking to them and saying, what does this look like to you? What is an engaging system? What is an effective system? What would make you come? Because a lot of our communities have solutions that haven't been recognized, identified, given legitimacy, but they're effective and work and could be included in an effective solutions. So those, I think, are the two big pockets. And in terms of pitfalls, I think some of the pitfalls obviously alludes to the conversation you had last week, data. Needing more data, it needs to be disaggregated, and it can't be just disaggregated Black, white, Hispanic, right? As David alluded to, it has to get to the subpopulations. It's like going out and understanding who you're serving. If you don't have the data, getting it, not using the data for ill, right? It's not, you de-identify that data, you get an understanding. It's not the time you share it with punitive systems. Trying to think we can have a one size fits all. Not seeing if it's effective. Like sometimes you have one predominant personality, you're like, population, you're like, yeah, this is working, but you're not actually seeing if it's effective for all of the populations that you're serving or wish to serve.
Yeah, it's a really good point, and especially relevant coming off of our last webinar, reinforcing the use of data and the need for data systems and data collections, and to really be intentional about that. Before I move on to the next one, I just want to say, David, jump in and interact with each other at any point. Really have this free flowing, and then just remind folks that we have the chat box, but then we also have the Q&A, and so please feel free to use those, and we'll try and incorporate them as we go.
Well, Tracy, I'll take you up on that. I think looking at things differently and having that different perspective, as Kim just kind of alluded to, and the fact that we need to give folks, from the community, and I don't get a chance to do this as much as I would like at the state level, but to really hear from a different perspective, where people are coming from. It varies from community to community, from different culture, culture to culture, if you will, and also kind of using that information to develop your strategies. I mean, we can all look at equality. Everything should be equal, but we really also need to, and more importantly, especially as it relates to racial equity, is look at needs. The individuals have specific needs that may be greater or maybe different, clearly, than the needs of others, based upon that systemic racism that Kima mentioned, and in some cases, not the systemic racism, it's the fact that people are coming from different countries to our state, and they have different needs based upon the fact that they are coming to us from a different place, literally. So taking all those things into account, and I would say it's our job to do so. I mean, it's clearly my job, but I think it's all of our jobs is to figure out the ways that we can do better for the constituents that we serve, no matter, where they're starting off from, and meet them kind of where they are.
Yeah. Thank you for that. I think that's a really good grounding of what are we here to do? You know, we are all brought to this job, kind of brought to this work to help improve lives, well-being in communities, and save lives. And so that is our common ground, and recognizing that all people, all communities are a part of that, and not just one dominant or predominant community. And so really taking account the differences and the nuance. So really appreciate that. So moving on to how maybe you could talk more about how Pennsylvania is doing this work from, you know, a general health perspective, and then more specifically, not just working towards equity, but being proactively anti-racist. And what does an anti-racism framework really mean, and why is that important?
Of course, that could be a webinar in of itself. You know, I can't speak for the entire state. I will speak from the perspective of our office. And I will say this too, just at the outset, the folks on the line, and some of which are friends of the office. I see Sina and Roseanne, Scotty, connected to our work with COVID-19. I'll get to that shortly. But many of the folks on the line probably don't know that we even have an Office of Health Equity. And the fact that it's been in existence since 2007. Some of the things that we focus in on is, of course, advocating, or really pounding the table for programs and services, collaboration. So that's why it's so fantastic to talk to all of you folks. We're looking at data all the time. I know you addressed that last week during your webinar, and programming and interventions based upon those, the data that we see, you know, focusing in on those that are most vulnerable. We have a state level group called the Pennsylvania Interagency Health Equity Team. And that group is made up of, you know, various state agencies like Department of Agriculture and Education and Human Services, you name it, we have it. Even more recently, the Office of the Attorney General. And PCCD is a recent entry into that group. And we look at ways that we can collaborate across the board as it relates to equity. I did not say health equity, I said equity, kind of looking through the purview of, for an example, of DDAP, which I mean, I know all of you are familiar with, and ways that they can look through not just a racial equity lens, but an equity lens in general, to improve the services that they offer. So that's PHED. We also do a fair amount of work under class, cultural, linguistic, appropriate services to make sure that our department is adhering to those 15 standards that come out of the Office of Minority Health around cultural competency, around language access, and that type of thing. We recently, so I can drop a resource on you here, and on our Office of Health Equity splash page on our website, you can Google that. You'll see that class toolkit is now, we have an external version of a toolkit that we've been working with internally for about a year. So you can find that pretty readily available. And we provide a bevy of resources to help folks administer those standards. We also, a couple of newer things with COVID-19, I did not anticipate probably 95% of my time being devoted to COVID-19, but it is. We have 12 different committees that are looking at about 15 different vulnerable communities. Just to name a few of those vulnerable communities, we have pregnant women and parents of extremely young children, racial and ethnic minority committee. We're looking at the LGBTQ community, those that are incarcerated, returning citizens, rural Pennsylvanians. Many of these, of course, touch upon some of the work that the folks on the line tend to do, which is why I have folks like Sina and Roseanne as part of this work. And these committees that we have are an eclectic group of folks. They come from academia, nonprofits, state government, health, of course, just to name a few. And it's a passionate group of folks that we're hoping to keep engaged as we go forward. We have 69 recommendations. They're now fleshing out those, well, really pretty much have fleshed out those recommendations for implementation. We meet every other week. Another resource, if you will, anyone that's on the line, we can invite you to our COVID-19 health equity response team calls. We have those every other week. The tent's never too big for that. And don't want to speak for the governor's office. I want to be careful not to do so. But I will say that the governor's office is engaging in talks around impacting systemic racism. We, in fact, some time ago, so this is not new to us, have been looking at ways to address systemic racism, because we know that that's really the underpinnings of poor health across the state, across the country. So we are in the process of developing an anti-racism institute. In fact, it's a 10-module anti-racism. It was supposed to be face-to-face. It's now going to be virtual, targeting PHET, our Pennsylvania Interagency Health Equity Team. We're bringing a few other folks into it. So we have topics like exploring power dynamics, science, race, and data, examining structural racism, exploring systemic, interpersonal, and personal transmission of racism, just to name a few. So we have that coming. The governor is speaking at pretty much the first session. So I'll stop there. That's just a little bit of what we're doing. A lot of people just know this. I think this is a pretty good time to get involved in these types of activities. There's a lot of interest, and the door is open, and our office is rushing through that door as effectively as we possibly can, and seizing this great opportunity to do things differently.
That's great. And I think you just listed, several resources for our audience, and we will develop a resource sheet to include some of the websites and resources you mentioned to share after this webinar, including, the website, the webpage, the resource equity webpage, and as more information comes out around the COVID-19 response team calls, and then as more information comes out around the Anti-Racism Institute. So we'll be sure to circulate that information and more as we go on in this conversation.
Can I add something, Tracy?
Yes, absolutely. I was just about to call you.
Yeah, and I think a couple things, because I actually am pretty impressed with some of the things that are going on in Pennsylvania. I'm not a Pennsylvanian resident, but two things I want to surface. I think a lot of times, when people talk about anti-racism, they have a lot of different definitions in their mind. And I think it is important for organizations to determine what their definition is. And for myself, I have this, I'm not a Canadian resident either, but Ontario has this anti-racism secretariat. And I really like their definition, because it says anti-racism is the practice of identifying, challenging, and changing the values, structures, and behaviors that perpetuate systemic racism. And the reason I like their definition is it's an action definition. It's that changing. It's really going into what your practices and your policies are, the values that you have, and changing them so that they are really looking at how to create equity, equality, justice for all, right? Which I think, especially in the substance use space, we haven't really gotten there yet. And then the other thing I wanted to mention around Pennsylvania is I do work, as I said, in other spaces. And one piece that I'm very passionate about is maternal child health and substance use, and really providing services in a harm reduction frame that really looks at a family preservation mode as opposed to separation. But anyways, all that to say, one space, Pennsylvania's done a lot of work around maternal child health, and I was advisor on this organization called CLASP that has done work. And one thing that they're doing in this space is creating a value-based payment where equity is included. And Isha and myself have written a paper on how to include equity as a incentive, something you pay for, incentive in a lot of these value-based contracts. And Pennsylvania and this fellow Doug Jones who I'm completely forgetting what his title is, but are doing this for maternal child equity. So I think the key piece here is, even though folks are working in the substance use space, unfortunately, inequity are rife throughout all the systems, but also so is innovation. And so really looking at some of the other systems, because as David has said, Pennsylvania has been doing a lot, and seeing if there's things that you can import and adapt as you go about that really active attempt to look at and create an anti-racist space where you're working.
That's really great. I really appreciate the other resources, and recognizing that we don't work in silos and how health just kind of overlaps, and it's the same vulnerable populations that are impacted by these different health issues over and over. To no surprise, as we look at how structures and systems are fundamentally work across all these issues. And really appreciate the Toronto reference. We're going to add that to our resource page for sure. And recognizing that there's a lot of terminology just being kind of used: equity, health equity, anti-racism. And so really appreciate kind of like unpacking what those different things means, and then how we could think more moving from just identifying it and talking about it, and then this really open word of addressing it. And so when you mentioned that changing the value structures, I feel like that really resonated with me, of like something that's really specific and fundamental, and has depth to it. So I think that's really important. But I think what you've already started to touch on as we move on to the next point is the intersectionality around this work, and recognizing that populations have these, it's not just race, it's like race and gender and sexual identity and justice involvement. And so there are all these other things happening in people's lives. We don't live single issue lives. And so recognizing that when we talk about racial equity and we talk about anti-racism, that we have to talk about intersectionality. And with that, Kima, I want to go back to you more to unpack this, because as you started us on this journey with talking about maternal health and other issues, how in your view do you think, or should we consider in ensuring intersectionality in our health equity work, especially from the planning all the way to the evaluation?
Awesome. Yeah. And I can't go back to my first statement. It really is including and going to talk to the people who are impacted, and not just your best friends that but like really just going out there, because people, again, not only do they have solutions, but they have understanding of their intersectionality and where they can go that's a trusted place to get care, and where they go that's not a trusted place to get care, and they can give you the exact reasons why it's not trusted. And that, I think, is incredibly important, because a lot of the pitfalls that come in this engagement, and I've been doing a lot of work in this space. One is like, we're here. I feel like after COVID and after the George Floyd protest, people were very interested. But what they did is like, okay, we're here, even funders, we're here, ready to give you money. Now you should care about us. And not only is that dangerous, but it's kind of absurd, because as I said, historically, folks have been treated poorly on purpose. Now, other communities and power structures are coming in and saying, we're here, we're gonna save you. You're not going to be listened to. It's not going to be an effective relationship. So really going in and listening, having the capacity to listen, having the capacity to not only listen, but innovate, and use those ideas to innovate and create new structures, but also recognize the structures that already exist, that have been put in place. One way to really engage communities is to understand what systems are already in place and supporting it financially. A lot of these really systems are effective, but haven't been supported. I think the other piece about the intersectionality, though, really is that no one size fits all. And as a Black woman, a lot of times it's like, well, this Black organization is going to serve all Black women. Is it serving LGBTQ plus Black people effectively? Is it serving young Black people effectively, older Black people from Jamaica versus Barbados versus Nigeria? And so having an understanding that no population, as David was saying, is monolithic, and really getting back to that listening place, but also bringing deep amounts of empathy and deep amounts of courage. This work is really hard. I don't want to go in and be like, I worked in a clinic for uninsured. I speak Spanish. I'm fluent in Spanish. I speak Portuguese. Having linguistic ability is not culturally effective, right? It is a whole, like, do not go in there being arrogant. Be as humble as possible. And a lot of the work I do is because I've made mistakes and I've learned the hard way, but I listened to the mistakes I made and tried to do better. And so the only way I think you really know that you're doing this work right is that you feel uncomfortable every single day, right? Because you're like, there is no such thing as cultural competence. You will not be competent in all the people that exist, but really trying and listening and doing it again. So as you plan, having people from community in the planning space, having people as leaders who are impacted, implementation, part of the implementation, telling you who's trusted, who's not trusted, why, maybe they're trusted for certain populations, not others. And then having them be part of the evaluation to say, what is really important to us? What are the outcomes that we want to see? In addition to whatever, I've worked for government, so whatever outcomes government needs, and you're rarely going to get away from that, but really having also outcomes that are important to and affect community. And if they are not being met, having the capacity to rapidly try something new, implement, evaluate, try something new, implement, evaluate, and really getting that buy-in and input from the beginning.
Wow. Can I jump in, Tracy? I figured I would learn a lot from Kima. We kind of practiced a little bit and I heard a little bit from her, but I'm so happy to hear more. I think just to kind of piggyback off of that, to me, folks on the line should understand, should realize that they don't need to know everything, but being curious and being interested in learning more, and not going into it thinking that we have all the answers. I mean, I've been at this work now for over 30 years. I try not to think that I know everything, and I try to learn as much as I possibly can. Even while I'm presenting, I'm trying to learn from Kima and others, and having a space to get it wrong. We clearly don't have all the answers, but we should not. I'll use one of Kima's words. We need to have the courage to try some different things. I think we also need to feel comfortable in really, kind of learning from our community partners, from our constituents, from the people that are receiving services. And then hopefully using some of that information that we get to craft our interventions and putting those out, seeing what happens, and then tweaking it accordingly. And not just, since we've always done it this way, let's keep on doing it this way because we feel safe and comfortable doing it this way. That's not going to meet the needs of the larger community. And I would hope that we would not just focus in on, kind of what we feel comfortable with. Again, using something that Kima just mentioned, is we have, some of it's going to be uncomfortable, and that's okay. But that we're giving it that shot. We're trying our hardest to do better than we did yesterday. And again, the opportunity is right there in front of us. Hopefully, we will seize it.
This is great. Again, if I feel we don't have slides, but I feel like on the resource page, as I take notes, that we could put a section on the page of maybe even principles. It feels like almost guiding principles here that you're discussing. Creating trusted places, listening, innovate, developing new structures, but also addressing the historic racism in current structures. The deep amounts of empathy and courage, things that you don't see so much in a technocratic toolkit, but that is so important and that we are so easy to forget. So thank you for that. Before we move on to the next one, I do want to recognize that this can be particularly challenging in, under-resourced or less populated areas, or, predominantly white areas, or that their changing populations are relatively new. For Dave, you talked a little bit about, recognizing the rural communities. And so for Dave or for Kima, how can we think about this for those areas that are more rural and less urban, or less resourced, or have, a different set of challenges as far as scale and population size and diversity? And I know for a lot of the counties we work in Pennsylvania, there are a lot of rural areas that are trying to do this work right. And so looking at those areas, how can we, or what would be some consideration?
That's an interesting one. Rural Pennsylvania is, I'm going to use the word complex. I've been as far northwest as Erie, and as far southeast, of course, as Philadelphia. And there's a big difference between Philadelphia and Erie and everything in between. I think identifying those communities within a county that are most vulnerable is a good place to start, and to focus in on the most vulnerable within a county, whether they be racial, ethnic minorities or not. Some of these counties are large and some of these counties are relatively small, but they in many cases, they have these pockets. But it's also quite interesting, the municipalities within the counties. I think maybe having some sort of a shared vision for the health and well-being of the citizenry of a particular county would be a good way to start. For all the people of the county, no matter what their racial and ethnic minority, constituent looks like. That's not exactly what I want to say, but basically, no matter who it is in that county, we want to serve everyone, or that particular municipality. We want to make sure that everyone is involved and engaged and empowered. I also see the benefit along those same lines of engaging youth. They tend to have, I'll speak for myself, more energy than I do. They tend to be more innovative than I am. They use technology that I'm adverse to. And to develop those folks and engage them in this, because they tend to have more open, they tend to be more open-minded than some of our more seasoned folks, me included. So, and faith-based communities, I'll leave it there, but just engaging those that may not typically be thought of in this regard.
Yeah. Thank you. But did you have any other elements to add about, how communities that are less resourced, and especially rural communities, can go about doing this, difficult work and uncomfortable work?
Yes, but I have to be honest, I'm going to answer it and go into question 4 at the same time. But something David said is so important. It's really looking at and supporting the most marginalized within your community. And there's this group called Racial Justice Action Center. And I always repeat what you said. It's like, why not lift the boat that's farthest down in the water? Because that is the only true way all boats are going to rise. Usually raise the top boat, they can breathe, and everyone else is still drowning under the water, right? If you lift that bottommost boat, then everyone can breathe. And so that's something I think all communities need to think about and look at. And it's something that then ties into the next one, because we all need to be advocates. As David was saying, we need to have a shared vision for health and well-being of all the citizenry. That requires advocacy across structures. And David can't be an advocate for money, but I can say this, like, we need to ask for more money to actually create that shared vision. And that shared vision is hard, though, when there's historical racism and bias in the way and all these systems. Because even with this prescription drug epidemic, this current one, people died because of the racist infrastructures we had in place. Like, it was so, racism in America was so pervasive, as we all know, that it was actually easy for Nixon to make war on drugs racialized. They're like, of course, those people are bad and should be put in jail without treatment for a health condition, right? And that thinking was pervasive in all of our systems. But what that did is create a system where you treat a health concern with prison, jail, taking away educational rights, housing rights, everything else. And then when you had an epidemic that was about other folks who had insurance who were better off at times, and to be clear, the early response to this prescription drug opioid epidemic was not about poor rural areas, right? It was like wealthy, it's folks who had insurance and could get the drugs. When that came in place, there was no systems in place to actually provide evidence-informed harm reduction or treatment services. That legacy of racism affected every single race, sex, or ethnicity, gender identity, sexual orientation. And so we really need to look at how this racism and racial bias, it doesn't just affect Black people, it affects our communities as a whole. So we go back and we think of what is that vision for health and well-being? It's a criminal justice, in my humble opinion, it's taking the criminal justice system out of something that is a health and social concern. It's not making it friendlier. It's taking it out. It's creating a healthcare system that is already rife with disparities because of that pervasive racism, and having it look at disaggregated data, having it look at the systems and the people who are providing the care, and making sure that they are providing equitable, high quality services that are culturally and linguistically effective. It's looking at the child welfare system and saying, how do you provide the social supports? And it gets to that social determinants of health piece that people are starting to look at. But I offer caution even with that, because a lot of folks in the substance use advocacy space are now saying, yes, let's get everyone into Medicaid. Yes, people need to have housing. Yes, I agree with people need to have food. I agree with that. But if the food you're giving or the housing you're giving are like, yes, people should have housing, they're like, yes, they should have the housing that's next to the Superfund site, that does not get us where we need to be. And why are the low-income housing near the Superfund site? Because racism is pervasive in all of our systems. Why is Medicaid not as culturally effective? Why does it pay so low and there's fewer providers? So you go in, and I love federally qualified health centers. I'm a FQHC doc, but you have those huge waits because very few people will take the Medicaid. Very few services, huge swaths of the South don't even have Medicaid expansion, right? And so it's really looking at, and thus working in coalition with housing advocates, education advocates, is the Medicaid advocates, and saying, how do we advocate for not just funding, but policies and practices that create equitable outcomes for all so that we have the best health and well-being for citizenry? And it doesn't, the last thing I'll say, it doesn't then become punitive. And this is where harm reduction comes in, right? We get in this space where like, unless people get treatment, if they fail treatment and don't go there, then they're bad and shouldn't get any services. No, I guarantee you, I can talk to 90% of these people on this call and find some health concern that they are not treating perfectly, and yet they still will and still deserve to have access to healthcare, housing, food, etc. And the same thing is for substance users. Whether you're in treatment, whether you decide to use or not, you still deserve and have the right to culturally and linguistically effective health, social, housing, and other services. And we need to advocate together to work and make sure that the taxes we pay are used in a way that's going to create the best health and well-being for citizenry. Sorry, I get a little heated.
No, that was great. And I really appreciate, you bring up like deservingness, and punishment has really been tied to how, racism has advanced this drug war. I mean, those kind of all go in the same sentence about this concept of who's deserving and not deserving of basic human rights and, basic needs, and how punishment around substance use goes beyond the criminal justice system and criminalization to these different institutions, child welfare, hospitals, treatment centers. So those are really good points. And they're particularly important because, there's continues to be this attachment to punishment and success and failure. And by removing access to basic needs, you are somehow helping, which is baffling in a lot of ways. So I think these are really concepts that are important to tie into the conversation. of racism. And you've started to give examples of, how racism shows up in other systems, whether it's acceptance of Medicaid or child welfare. But David, I want to switch gears a little bit to you. And you started talking about, the work at the state. How can you speak more to how racism or anti-racism or equity is kind of being identified and addressed and discussed across, across systems, sectors, and within other institutions?
Yes, where to start? I think I'll go back to maternal child health that Kima mentioned. Many of you, or some of you, may not know that there is a grave disparity between African American and Latino moms and mortality versus white moms, and same thing with children. So there are more children of African descent and from Latino families that are dying, at higher rates than white children. And what does that say about our systems that in many cases are failing those moms and those children? So, looking at implicit bias, some of those things I kind of mentioned earlier in regards to cultural linguistic appropriate services. So one of the things that we're doing, and I did not anticipate the benefit of this across state departments, but one of the things that we're looking at doing is providing some of the concepts around class, culturally linguistic appropriate services, outside of the health realm. So it makes sense, obviously, for public health. It makes sense for human services. But some of the concepts also make sense for other state agencies, in that we should also be culturally competent, under agriculture and under transportation. We also should be looking at data that speaks to the most vulnerable populations that access services, again, outside of health and human services. And intersectionality really does make a difference, which is why we're bringing all these, or many of these state agencies to the table as it relates to our anti-racism institute. Back to maternal child health, protocols, within, and Kima, I'm sure, well, I'm not sure, I know, knows this way better than I do, but why is it different for, why is an African-American mom treated differently than a white mom when they walk in the hospital, expressing certain pain in their, in their abdomen? There should be protocols in place that the same questions that are being asked of one mom should be asked of the other mom, and there should be accountability to ensure that happens. So I think those are just a kind of a couple of things, and to me, that same type of scenario should be in place as it relates to substance abuse. The same levels of treatment should be offered, no matter if that person is, coming from the LGBTQ community, whether they're African American, whether they're coming from another country. The same opportunities for them to, receive treatment should be across the board, which is really at the nexus, the crux, I should say, of what health equity is, that everyone should be able, should have the same opportunities to live the most, the healthiest life possible. It doesn't say that they should have that same opportunity, no matter what their race and ethnicity is. It's just across the board, and that's something, of course, that we focus a lot on within our office. Hopefully that answers your question.
That was great. Thank you. Before I move on to the next objective, I just wanted to revisit what Kima brought up around advocacy and the importance of advocacy. And, sometimes when, I talk to folks, advocacy is, people perceive that as, towards legislation or lobbying. And so I think that there still needs to be more of an understanding of what advocacy means and the different ways you can be an advocate, even if you are operating within large institutions or if you're operating within government institutions. So start with Kima, and then Davey, you have more to add. What are the different ways advocacy can look like, especially for our audience members, who many of them are a part of local government agencies or healthcare or treatment institutions, or other areas? What are different things to consider for folks that do or should become advocates within the ways that they're capable?
So a few different ways. As a provider, there's individual advocacy for individuals and advocacies for populations, advocacies for systems, and all of that counts. I totally steal people's ideas all the time. So that's the humility, right? But there's this great youth advocate in Boston who said, everyone provides a contribution. Don't let you think that unless you're out there protesting that your advocacy doesn't count, because everything you do is a positive contribution. And I think he's right. So on the ground in this space, kind of alluding to what David said, if you have a client that's not getting equitable access to services, it's one, advocating for that patient to get them. It's advocating for the other provider that you're perhaps doing the warrant handoff to actually provide them. And holding them accountable for that provision. It can be advocating on a citywide level for populations. Unfortunately, like I said, these issues, marginalization, racism are rife everywhere. And so for issues around housing, why can't my clients get access to housing? Can I work with the Healthcare for the Homeless and the Housing Coalition and the other coalitions to say, a lot of these policies don't have to be legislative. Like, let's talk to the housing department and say why they have these barriers in place, and let's eradicate them. A lot of this can be done actually with regulation, with conversation. I was talking to this one substance use service provider in California who does a lot of work, as I mentioned, in the child welfare system is an important space for me. And they're like, we get to have family preservation in other instances where kids are taken away because we sat down and sat with the child welfare agency, said, these are the services we provide. These are the services we offer. We will wrap mom up. And so it's that kind of advocacy. Obviously there's advocacy on the larger level, and that even doesn't mean lobbying necessarily. It can be education. A lot of the policies and procedures that are put into place, and this is something very much for government officials and something I did as government officials, are just put in randomly. Honest to God, in substance use, I swear people just make up evidence. It's just like, it's so random. And it's like, well, it's the same with syringe exchange. Tons of evidence to say it's effective. People are like, nah, it causes people to use more drugs. Well, that's just not accurate. Right. And so some of that advocacy can be education, providing materials and ways that whatever constituency you're talking to can hear, that again gets to listening to people, gets to listening to what their motivation is, and offering the materials that can help them understand however that is, whether it's in political language, whether it's in cost benefit language, whether it's in those kind of constructs. And then the last piece of advocacy that I'll talk about is really working with impacted populations to know their rights. Having people, I don't like to use the word empowering, and I can't exactly explain why, but it's a little off-putting for me because it makes assumptions that I don't feel comfortable with. But working to have those know your rights outlook, so that folks are advocating for themselves and advocating with all the facts and figures that they need. Unfortunately, a lot of our spaces don't allow people access to lawyers, and as someone out in the criminal justice system, I can't quite explain that. But how do you advocate for yourself? How do you know your rights? How do you push back when people want to say that XYZ is the fact when it's not? And so there's many, many more, which I'm sure David will allude to.
Mm-hmm.
Well, I'll drop a few. The way I kind of am picturing advocating and is folks that are allies. I'm thinking of a picture of of a young white person standing in between the police and, you know, Black Lives Matter protesters. You know, that's a stark example of an ally, but I mean, that's been going on for many years. You know, back in the 60s, if not before, there always have been allies that have helped those that need it the most, you know, receive some of the things that they greatly need. Kima, you mentioned kind of looking at systems and that, you know, things can change with conversations. Educating and advocating around systemic change. You know, none of us really want to do work today that's only going to last a short period of time. Wouldn't we love to do things or work on policies and practices that when we look back 15, 20 years from now, we can still see the change that we put in place? That's what I'm looking for. I mean, I'm not going to be doing this but for so much longer. I hope to do it for as long as I possibly can, but there'll be a time where I'm not doing it. And I want to be able to look back and say, okay, well, you know, some things that I worked on and didn't happen overnight, but look, that change still exists. So I think, you know, looking at systemic change and also too, again, something along the lines of what Kima mentioned is engaging others and listening to individuals and their issues. So we would go out, we had one program I did not mention to you. We have something called Public Health 3.0, and it typically is in rural communities, and it's a county-based kind of health coalition model that looks at certain chronic conditions, one being substance abuse, in various counties. So I would go to, I've mentioned this county, I guess this is gonna be the second time, one of my favorite counties, because it was one of the first counties I went to. It's Fayette, Pennsylvania, Fayette County, Pennsylvania. And one time I had a listening session in Fayette County. I wanted to hear from the residents. I wanted to hear from those that, you know, were impacted the most. I did not anticipate tears being shed. You know, I just thought they would say, okay, well, this is wrong and that's wrong, but I didn't necessarily expect to have the emotion of in this case, this was a practitioner. I'll never forget it. She was a practitioner. She was I want to say she was a nurse, and she was talking about the fact that her clients are in a very tough position because they didn't, you know, their birthing centers, the access to care were closing all around her. So this lady was in tears. I would not have known that if I didn't hop in my car and drive 3.5, 4 hours to Fayette, Pennsylvania, and actually, you know, set it up in such a way where I was in a position to listen. And once you're in a position to listen, they know that they have an ally in you. And I always throw back out at them that, you know, we need your help as much as you need our help, because we cannot do this. I mean, alone. I'm an office of 2 people, basically, and interns. But we're able to accomplish a fair amount because we have allies. We have people that are passionate about the same things that we're passionate about, that really want to get the job done and have expertise that I don't have and contacts that I don't have. So I think really engaging individuals outside of your operation really kind of spreads your tentacles out in a much needed way.
Thank you. Yeah, I appreciate how we got back to, you know, the big concepts of just listening and empathy and how that goes, and recognizing that we don't have all the solutions, and how to see how others have the solutions if we just take time to communicate and listen. So thank you for that. I'm looking at time. I do want to, you know, leave time to open it up for the audience. So I will try to do so, but moving on to the next objective. So I really want to start getting in, diving deep here in this objective on service delivery. So much of the work that Vital Strategies supports and that is in our audience is service delivery. It's providing the naloxone distribution. It's providing syringes or access to other harm reduction services, or access to buprenorphine treatment or other forms of treatment. So what are some really key things, whether it's preventing, identifying, or addressing inequities that folks on in service delivery specifically need to consider in their work to ensure that they are addressing inequities, that they are advancing, an anti-racism framework? Oh, Kima, you want to go first?
Sure. I think, it gets me back to that history question, and not history, you don't have to go back necessarily and read tomes, but it's understanding that these are built in. You're not truly starting from an empty platter. And from that is people's values and structures. And so really having to sit down and talk with your staff and understanding it's a change within the organization, as well as a change in how you provide services and external to the organization. Because my mom always said, if you do it at home, you'll do it when you go out. So if things aren't right in the organization, it's not going to be right when you deliver the services. And so really looking at and assessing, again, it gets back to that data that you had the conversation on last time, right? It's how are we treating people? What does that look like? Are we doing the best for all communities that we can? I think the next step, once you assess what that has looked like, what your history has been, it's where are we now? What does our organization look like? What are our policies, principles? Do we have some of those health equity principles in place? Do we have a diversified workforce? And by diversified, I don't just mean race, ethnicity, sexual orientation, gender identity, but folks with lived experience, impacted populations, just the real whole gamut. What does our workforce look like? And what are their values? And do we have shared values? And then that gets, to looking at the data actually in a different way, because then you start looking at the data and seeing where the differences and disparities are. And it's less of an identifying and more of a how are we going to create solutions. And in that space, again, it's getting out and listening to what's already being done, but it's also innovating and often putting together a community advisory board or some other way to gather input on a regular basis of what services you can be providing that you're not already, and innovating new ones that you never thought. It's looking at the structure you have and the community advisory board and saying, why don't you try X, Y, this has worked for me or has not. I think being able to admit, though, and this is a key point that well, actually two key points I will admit. There's a lot of work towards implicit bias training. This is incredibly important, but it's not an end stop. There's this guy, Honor Hernandez in Boston, who said, it is no longer implicit bias once you've named it. Right? You cannot have 4 years implicit bias training because now there's a problem. So now it's really working on how to explicitly change that and holding the institution and staff accountable for making those changes. But the other point is it's not one size fits all. And sometimes your institution is not the best to serve every client. And it's admitting that, right? And it's having governmental and other structures admit that that is not the best case. And I say this as a provider who often had patients who didn't want to see me because I was Black. And then folks would say, well, they should see you. And I was like, well, that's just a malpractice suit waiting to happen, right? If someone is really not trusting you and don't want to work with you, and you are now subjected to someone being racist to you, it just creates dynamics that are not necessarily healthy for an organization. So that's one piece, but also sometimes organizations don't have the skill sets, don't have the population. If you have women who want to be in a women only group and you serve predominantly males and you're putting the woman in, maybe that's not the best fit. So again, listening to that community advisory board and saying, should we be doing this? If not, and it doesn't get you off the hook, it is then saying, where should we refer people? Where do people want to go? How can we not only maybe refer folks, but then learn from that institution so that we can do better since we are not effectively serving XYZ population. And then if someone leaves, looking at who you're not serving and looking at if someone leaves and seeing if there's a capacity kind of to do an exit conversation, look, I know you don't want to be here anymore. Was there something we could do better? I think also helps to start to address those. But a lot of this stuff has been done before. It's admitting that it needs to be done, having the principles and values in place to say that you're going to go on that ever learning, humble journey, and then looking out and working with community on how best to implement, and then how to evaluate. Got to keep evaluating. It's that rapid evaluation. Look at the de-identified, disaggregated data, evaluate again, and being honest that the times and people change and communities change. And so you will keep evolving.
David, I don't, if you had anything to add, again, I'm looking at time, so I might be rushing through a little bit here at the end.
No, I mean, she nailed it. One thing I would say is, we talk about diversifying staff, and we are nowhere near it within state government. For example, it could range between 3 and 10% of the workforce come from racial ethnic minorities. But when we have those folks on board, it's about meaningfully including them in our efforts, giving us an opportunity to really provide, that input from the backgrounds that we have that may be different from the backgrounds of others that happen to be in leadership positions. So I guess I'm saying it's not only diversity, but it is inclusion, meaningful inclusion.
Thank you. So we're gonna get to questions in a second. So if folks could start putting things in the Q&A or in the chat to just start populating that so we can dive right into the Q&A. So please do so. But as folks are doing that, moving on to some of our final points, integrating racial equity, understanding approaches and tools within your organizations, institutions, and staff and stakeholders. So we've had this discussion, and now let's do the work. And so I think one of the questions here is like, what are some tools that could be particularly helpful to get folks started, or some steps to get folks started, or how tools and resources that are out there can be adapted for folks to integrate in their organizations and their staff and stakeholders.
Guess I'll start off real quick. Guess a shameless plug, but I'm just gonna go with resources that I'm aware of. On our website, you have the class toolkit, which again is recent. Only been up there for about a week or so. I think that's a good place to start. On our website as well, it's now getting a little bit old, but it's our 2019 Health Equity Report. And within that report, we do some level setting. And I think that's important as a tool to make sure that there's a shared understanding of what health equity is. And we have some definitions that we didn't make it up. We pulled from WHO and, American Public Health Association. So doing some level setting as to what equity is, using some of those graphics, the ones where three different folks are looking at the baseball game, or I think the ones that you'll see on our website with the physically challenged, a woman and the riding the bikes. I think having common understanding of what health equity is, what health disparities are, those types of things, I think is a really good place to start to make sure that everyone's on the same page. I'll leave it there.
Yeah, and I think, and I'm gonna go to question 7 kind of in the space. One piece that I think a lot of folks struggle with, but is a way also to get staff on board, is how to ask people about data. Folks need to self-identify who they are, right? And we don't do a good job with that. And so learning those tools, and that's for race, ethnicity, sexual orientation, gender identity, learning those tools so that you're doing it effectively, compassionately, and in a way that builds trust and partnership is a way to really then see how you feel about populations, right? And so sometimes I think you can have trainings. Sometimes I think you need to practice change to really get to see how that's going to work in real life. Another kind of tool, I don't know, this is so old, but it's something called NIATAX, and it's something substance use treatment programs use to change the way they do treatment to try and offer same day treatment, which seems absurd that people don't offer. Anyways, but it's out of, I want to say, University of Wisconsin. I think it's a tool that, and I've used it and adapt it for other things, but essentially it's like a rapid assessment tool. You change the way you practice, you do a walkthrough with a client to say, how is this working with the client? And then your staff does a walkthrough and say, if I was the client, would this work? Then you look at it and say, how could I be more efficient? So it's not only efficient for my staff, but it's efficient for the clients who are being seen. And then you try something, you make a change, a small change, a big change, and you evaluate whether it worked. And not using that necessarily for same day engagement, but using that thought process for how you're going to go about the practice change and culture change that's necessary for health equity. So just starting to say, let's just walk through the practice with, an African-American male, a Latinx from Puerto Rico woman, like saying, like, how is this working? And using it as a tool for those other conversations around implicit bias, around how you talk to and allow people to self-identify, these other pieces. And so working things so that people can see a little bit of success. Like I said, this stuff is hard. So either see a little bit of success or a little bit of a path forward so they don't give up, because that's often what happens. It becomes hard and people are like, oh, forget it.
Mm-hmm. Yeah. Okay, so we have a little over 10 minutes left. I'm not seeing a lot of Q&A, but Marco, do you want to open it up if folks could raise their hand if they want to want their audio on to say what their questions or comments are? I don't see any hands raised.
Yeah, I don't see.
So just take a second.
Just got one. Robert. Oh, so let me go ahead and unmute. I'm seeing a couple. Robert?
Hi, thank you very much for allowing me to speak here. My name is Robert Oakes. I am part of the South Pittsburgh Opioid Action Coalition. And I just was wondering from Ms. Kima, she had a definition, Toronto definition of racism, which I thought was awesome. Is there any chance that someone could put that in the chat so I can copy and paste it? Because that was phenomenal.
Sure, I will do it now.
Thank you so much.
Kima, can you remind us one more time what that is?
Sure. It's the Ontario Anti-Racism Secretariat, and their statement is anti-racism is the practice of identifying, challenging, and changing the values, structures, and behaviors that perpetuate systemic racism.
Awesome. So we'll be sure to drop that in. I don't know, Kima, if you have the link, but we'll definitely be sure to circulate afterwards.
Thank you.
So,
thank you, Tracy.
For sure. Thank you. Anyone else, any other raised hands? Marco, I'm gonna leave it to you as the host to mute and unmute folks. I see we have a Deb Bard.
Sorry,
Deb,
I
yes.
muted myself. Sorry, Deb, you are unmuted. Go ahead.
No problem. I have been working in the field of substance use disorders for a lot of years.
She was muted, Marco.
Oh. Sorry, I was trying. I don't know what's going. I apologize. I'm not sure why.
Deb, did you mute yourself?
Oh,
There, it says unmuted. Oh, am I here?
Yes.
Yes.
Okay, wonderful. I wanted to just say something. I'm not sure what context to put it in, but I've worked in the field of substance use disorders for quite a while, like 30 years or so. And I'm currently the project director for a Narcan grant at a hospital at Lancaster General Hospital in Lancaster, Pennsylvania. And I think that I really, unless I missed it, I really didn't hear the word stigma mentioned very much. And so I know that within this field of substance abuse, there's stigma on top of stigma on top of stigma, depending on, if you're a member of a minority, if you're, live in a rural area, if you're a certain religion, whatever the case might be. And just the fact that you have a problem with substances, is another layer of it. So I'm just wondered if the speakers would like to comment on addressing stigma or if that's just a given in the context of everything else that they said.
Yeah, unfortunately for myself, it was just a given.
Okay.
Unfortunately. And with that given is why having to go back and really undo all of this, right? And that is why when people say, and that's why I think there needs to be that cross advocacy, because people are like, oh, let's make sure that someone with substance use has access to Medicaid. That ain't going to get you there. There are doctors who won't see people who are actively using substances. There are social service housing. That's, when I was talking about the housing, people have discriminatory housing policies because you use substances. And so it's making sure we are part of all of those conversations, because you're absolutely right. It's like every which way it is used as a tool against, but even that tool against, even that stigma is embedded in the way we think I would say in the United States have to have the have-nots, the good, the bad, the deserving, the to be punished. And it is all part of that. You can come over to our country and decimate thousands and millions of people and think then that it's yours. And that it's like that really racist infrastructure that allows us to perpetuate a system of the have and the have-nots with the substance use as well.
And I think just, that population is certainly self-stigmatizes. So they're coming from the basement up. I don't even deserve this. I shouldn't even have this, that kind of thing.
And the only thing I would add, I guess, goes back to, those cultural nuances, is that it's pretty interesting to me. It's fascinating to me when you look at the different groups that reside in the state of Pennsylvania now, from the Bhutanese to folks from Somalia and different nations in Western Africa to Pakistani and just on and on. The stigmas are different. They may have similar root causes, but it's different. And I think it's incumbent upon us, and to me, again, fascinating and interesting, that we are aware of some of those. Can't be aware of everything, but that we're at least aware and agile enough that stigma exists differently depending upon where folks come from and the myths that people adhere to, believe in, that type of thing. And it's youth and adults. I mean, it just goes on and on. It's pretty fascinating to me. We just need to be cognizant of them as much as possible.
Thank you.
And, I would add to that, because that is so important. And also then the way different societies treat people who use substances. Like as punitive as the United States is, there are some countries that are much worse, right? Death penalty. Let's look at the state of the Philippines. And so how families, how loved ones, how not assuming our responses are going to be creating a response that is going to be helpful and preserve the human rights of the individual we're serving. It can get, as a provider, it can get tricky because you're like, oh, definitely, let's bring the family in. And then you're like, ooh, let's.
All right, so we have about 5 minutes left. I don't see, I think there's one question about the webinars. The webinars are going to be archived at the Overdose Free PA.PIT.edu website that is on the screen. So, and then I believe PERU will also circulate this information in a website so that folks can access the webinars.
Yes, and I will put that in the chat, Tracy. There is the link directly to Overdose Free PA to those webinar resources. If you do access Overdose Free PA, you can just type that in and it'll be kind of on the right-hand side, but that link will take you directly to the webinar. So previous and this one.
Great.
Yes, and I also, just to let everyone know, I did put the evaluation link in there as well. So if folks could please fill that out and let us know your feedback. And then also there's the QR code if you just want to open your phone and hold the camera up to the screen. It should take you right to the link. It's pretty quick.
Awesome. So that we have 3 minutes, and I just want to take time to thank our speakers so much. Thank you, Kima, and thank you, David. This has been such a great conversation. I really appreciate it. And it went by really fast. I always think 90 minutes is longer than what it is, and it's went by really quickly. And I think that's just a testament to how great this conversation has been. So with that, are there any parting words that you would like to leave our audience with? I know I rushed a little bit towards the end. So if there are any last minute highlights or principles or guides, please, Kima.
Sure. Humility, courage, not being afraid to make mistakes, and entering with a space from love and empathy, and as a friend of mine said, with radical respect for others.
Radical respect.
I guess what I would say is there's a great opportunity for us going forward to really make some changes that chances are most of us that are on this line, if not all, would really want to see. I think I'm not going to politicize it, but I will say, due to the fact that things are going to be changing at the federal level, and that we still have a year more of Governor Wolf, I think we're in a pretty strong position to really make some substantial change, even with the roadblocks that will inevitably be put in front of us. And it's time for us to, I guess, roll up our sleeves and work to just step around those obstacles and move forward.
Great. Well, thank you. Thank you again. And thank you to our audience for participating. And we shall share the resources and the link. And everyone have a great day. Thank you.
Thank you.
Folks.
Thanks for having
Bye-bye.
us. Bye.
Thank you,
Bye,
everyone.
everybody.